I'm so excited to sit in front of our CSIM conference audience today with internists from all across Canada to conduct our very first live podcast episode with Dr. Hanmiah. So Raj has taken the liberty of actually recording these 3 pre-CSIM podcasts already, and in those podcasts we talked about 7 papers that were really good, but just didn't make the cut for the top 5. So like we said, you can go on medicinepods.com to listen to those. But now, the hour we've all been waiting for, it's time to go over, according to Dr. Hanmiah, the top papers of the year. So we're going to be giving you guys these in rapid form, and the aim will be to have some question time at the end. Okay, are you ready?
I'm ready, Zahra. Let's try this new format out.
All right, can you kick us off with the title and the research question of the first article?
So to start with, I have to disclose any conflicts, and I have 0 conflicts. I only make money through OHIP, so I have nothing to disclose. So the first article we're going to talk about is blood biomarkers to detect Alzheimer's disease in primary care and secondary care. This was published in JAMA in July of 2024. The role of the question in this article is basically to prospectively evaluate blood biomarkers for the diagnosis of Alzheimer's disease in both a primary and a secondary care setting.
And I think it's helpful to preface this with just some, sort of facts of Alzheimer's disease is often associated with amyloid plaques, and especially in the US and other centers, they've been using different sorts of techniques to actually be able to detect that there are amyloid plaques in the brain. And we'll go into that a little bit if you can tell us a bit about our study design and methods.
So this study was actually done out of Sweden, so it's a Swedish study. What they did is they recruited patients, so this is not all comers. These are patients who already had suspected cognitive impairment. So this would be in a sort of a higher pre-probability group. So they used these patients, and then they eventually had them assessed by either primary care or the secondary care specialist. And then they also did blood biomarkers on them. And then they, of course, saw what the effectiveness of the blood biomarker is. It's important to sort of give you some background on what these tests are. So blood biomarkers, so first of all, what is the diagnosis of Alzheimer's in this study? So the diagnosis is actually based upon an LP. So they do an LP, and they look at the biomarkers of the phosphorylated tau 217, and they look at the amyloid beta 42 to 40 ratio. And in the CSF, this has been shown to be actually fairly predictive of having Alzheimer's disease. The other alternative, if people couldn't get an LP, is they did a PET scan. So those were the gold standards for the actual diagnosis of Alzheimer's in this study. And then they're, of course, using blood biomarkers as an alternative because, of course, LPs and PET scans are not that easy to do and somewhat invasive. So that's the background of what we're looking at here. The blood biomarkers that they're studying, they looked at 2 of them. One was the phosphorylated tau 217, which is the same thing that was in the CSF, looking at a ratio of that in the blood. The other is this score called the APS2, which is using the amyloid protein and the phosphorylated tau ratio and using that in a sort of a logistic regression analysis that they have, and they come up with this score. Those are the 2 blood biomarkers that are being used here.
And then if you can also go over their primary outcome and their secondary outcome as well, that would be helpful.
So again, mostly they're looking at the diagnosis of Alzheimer's in this study, and it's a prospective study. Again, I said it's Swedish. They ended up to give you an idea what the patients look like. They're basically about 50-50 female to male. Their mean MMSE is about 27. In terms of the diagnosis of all these comers, about 30% end up having a diagnosis of dementia, and about 45% have a diagnosis of cognitive impairment, mild cognitive impairment. And the remainder are just suspected cognitive impairment. In terms of comorbidities, these patients are about 50 to 70% cardiovascular. There's cardiovascular disease, about 50% have hyperlipidemia, 20% renal disease, 20% diabetes. Basically exactly what you might expect for a patient population in this group.
Yeah, I agree. I think we can all agree that the patient population and their characteristics were relevant to our patient practice. And can you tell us our main results?
So the main results here, to summarize basically, let me also sort of elaborate that they have two different ratios that you use here, a single cutoff and a double cutoff. So a single cutoff is what we might be used to, where you simply look at the value and it's either a positive or negative based upon the value, right? Either you have a positive result or a negative result. The double cutoff is where they have an upper result, and if you're above that, it's basically considered a positive test. They have a lower result, and if you're below that, you're considered to have a negative test, which then means that you have an intermediate group where the test doesn't really give you a positive or a negative result. So why would you do a double cutoff? Well, because it gives you greater positive predictive value, particularly for people above the upper cutoff. And the argument there would be that really you want to have a strong positive predictive value when you're doing a test like this in a population-based way. So that's where the single cutoff and a double cutoff come. And effectively, what you'll see is that their positive predictive values are roughly about 90%, and the negative predictive values are about the 90% range. You'll see that in the double cutoff, you do end up with between 6 and 13% of the population that has an intermediate result, which means no real effective result for them, either positive or negative.
So the results are pretty interesting and remarkable, but throughout this hour, you're going to teach us to be good stewards of evidence-based medicine. So, we'll talk about the limitations, but actually, first I'll let you talk a little bit more about the specialists and the primary physicians.
So we just talked about the test results. So what's probably more important to people is how does this test compare to how the clinicians do? So you looked at the diagnostic accuracy, and again, the gold standard in this study is going to be the LP or the PET scan. So when they looked at the specialists in the secondary care cohort, they looked at the specialists, their diagnostic accuracy was about 70%. And that compares, like I said, the diagnostic accuracy of the blood test is about 92%. When you look at the primary care group, their diagnostic accuracy was about 58%. And that again compares to about 90% roughly with the blood test. So you see that the blood test actually, at least in this study, has a diagnostic accuracy significantly greater than the clinical diagnostic accuracy would be if you exclude blood biomarkers. So that would be the aspect here. The other thing I'll mention is that when they do an analysis with a double cutoff, remember again I said the double cutoff theoretically gives you a better positive predictive value. When you limit that analysis to just the people with cognitive impairment, meaning not just the suspected, but the actual people with mild cognitive impairment or dementia, their positive predictive value actually gets up into the 97% range for that group.
I really do like how they included the primary care physicians in this study. It makes it more practical and relevant, I believe.
So I think the next question I should answer is, why did I pick this study, right? Well, I picked this study because I thought it was very interesting because we practice general internal medicine, we practice on the wards. This is a massive issue, right? Cognitive impairment, dementia, we're seeing it every day. We see that the proportion of patients that have this is just increasing all the time. And we really have nothing that we have to impact on this disease at this point. But that's not entirely true. There are 2 monoclonal antibodies that have just come out that have some ability to impact the course of this disease if it's used early. There's about multiple drugs in preparation, sort of in various stages of development right now. And I think it's going to become very important that we find a way that we can predict this disease accurately in the early stages where maybe we can have some impact. Because this is such a massive public health issue. It's such a massive issue for us as a society. And so I thought that this was sort of potentially the beginning of a new era in Alzheimer's. Obviously we're not there yet. I wouldn't pretend that we're there yet. But I thought it was very interesting because I don't think we understand where Alzheimer's disease is right now and where the new research is. And I thought this was very interesting to see that it's sort of new eras are coming in this.
I love it. I think it was really neat and definitely represents a paradigm shift in the treatment or at least the diagnosis of Alzheimer's disease and kind of the tip of an iceberg in terms of what I think are the studies to come in the future. Briefly, if you can just mention a little bit of the limitations of the study and then we'll move on to the next one.
Well, obviously the main limitations are that this is just done in Sweden, so it's not highly representative of maybe all populations. It's a relatively small study. And what's the gold standard? There you can question what the gold standard is. And so I think this is early, but it's consistent with some other results that have come out about blood biomarkers, but we're by no means definitive yet. But this study is small, but I think does show us some relevant results.
Okay, excellent. So next we have a pretty cool study, and for those in Hamilton and I suppose in Ontario, you'll see some familiar author names in there as well.
So this was atrial fibrillation recurrence in patients with basically transient onset atrial fibrillation detected during hospitalization. This would be for non-cardiac surgery or medical illness. I will say I did not pick this. It's a hometown study. I did not pick it because of that. I didn't actually realize that until after I picked it, but it is a hometown study done here in Hamilton.
We believe you. And what was the research question?
So the research question really is, in this population, which is obviously very common, atrial fib develops during hospitalization and then resolves. Like atrial fib must resolve. What's the risk for the AFib recurrence in this population over the next year? That's really the question that they're trying to answer here.
So a really important question that I think all of us encounter relatively frequently on the hospital wards. And what was their study design?
So they, again, it's Hamilton based, so they looked at the 3 academic hospitals in Hamilton. That's where they recruited their patients. And they looked both on the surgical floors and on the medical floors. And they would look for patients who developed atrial fib and then would revert out of atrial fib during the hospitalization. And then what they would then do, which was interesting, is if they had a patient who met that criteria, they would look for a patient on that ward who didn't develop atrial fib, but as a match control, someone who had similar characteristics. So they would actually match each patient with another patient on the ward. That could be the surgical ward or the medical ward. So they ended up with about 139 patients. And they were equally split between the medical and the surgical, and their matched cohorts were also medical and surgical, in equal proportions.
I really liked how you had that little kind of matched cohort piece. I thought that was a neat part of the study. And what outcome were they looking at?
So the outcome is really just the development of atrial fibrillation over the next year. Their definition is actually atrial fib that lasts greater than 30 seconds. That was their definition of what atrial fib represented. And again, it's over a 1-year mark. How did they do this? Well, there's standard medical care, so basically during routine visits, if you pick up atrial fibrillation. But really, the main way they tried to do this is the patients all got a 14-day patch monitor, and that would be at the 1-month mark and at the 6-month mark. So the patients would all be asked to do 2 14-day patch monitors during that year. And then, of course, any atrial fib that was picked up during the routine clinical would be recorded as well. And that's really how they examine these patients.
Excellent. And so this is a local study. So what did their patients look like that they included?
So their average patients were, the average age turned out to be about 71. They were 60% female, so a little bit more female than male. Their EF was about 57%, so actually most of them had preserved ejection fraction. But the one area that sort of stuck out a bit is it was over 90% Caucasian, so it's probably not broadly representative of the population, but that was a study population that existed here, was 90% Caucasian.
Okay. So I think, beyond the caveat that you mentioned, throughout Canada, this being a Hamilton study, I think most of the Canadian internists in the room can identify with this patient population. What were their main results?
So here's the main results. So over the year, their results were that 33% of their patients developed atrial fib in that 1 year, versus in the matched control, only 5% had atrial fib developed in the year. Of that, it's important to note, how did they detect the atrial fib? Well, over 70% of them were detected by the patch monitor. So it's important to realize that most of this is actually detected by active surveillance, not by routine clinical management. So they had to really look for it to find it, but that's their main result. Obviously quite significant in terms of statistics there. The average amount of atrial fib that they found was about 9 hours. Remember I said there was a 30-second was positive, but their average amount was about 9 hours. In terms of the majority of patients had, about half of them had about 24 hours of atrial fib, roughly, and a number of them, of course, had less. They looked at a bunch of variables in terms of what predicted if you have atrial fib, and they looked at a bunch of clinical variables. The only thing that actually turned out to be significant was left atrial size. Now, their numbers were quite small when you got to the really big left atriums, but they did find left atrial size was significantly correlated with with whether you develop atrial failure next year.
Very interesting results. And before we get into what we can take away from the study and why you chose the study, can you take a second to describe some of the limitations that we should just be cautious of as we interpret these results?
Well, I think the main limitation, number one, is of course this is a relatively small study. I said it's about 140 patients. It's done only in one center, really in one city. So again, and is it really represented the entire population? There are some limitations there for sure. Those would be the main limitations. And then the big thing, of course, is this study is about whether you develop atrial failure. It does not really tell us anything about outcomes yet. So we don't know what you have to do with this information, and I think there's lots of work being done about what do you do, and you can try to make corollaries based on other studies. But really at this point, it's a bit unclear what this means from an outcome perspective. But again, I think this is the first prospective study that really shows us that patients who develop atrial failure in hospital, and this is super common, we see it all the time, but patients who develop atrial failure in hospital do indeed have a fairly high rate of developing some level of atrial failure in the future, or over the next year. How significant that is clinically, I think is still to be fully determined. But this study, it does definitely show us that it's not as limited as we may have always thought. It is actually quite common.
So let me push you on this a bit. Does it or how does it change your practice?
So for me, again, I said there's limitations of what would I do about it. But I think for me, this does change practice a little bit, and that I'm going to be probably actively surveilling more patients who develop atrial failure in hospital. And for me personally, and I think there's, everyone's going to be a bit different. If you had a high burden of atrial failure, I'd be more willing to anticoagulate, particularly if you have a high CHA2DS2-VASc score. Right? That's going to be my takeaway from this.
I think that makes sense.
Yeah.
And why did you choose this study?
Basically, everyone in this room realizes this is one of the most common consults you'll see if you're in medicine, right? This is super common. We're seeing it all the time. And we really don't know what to do. And I think everybody has slightly different practice patterns about this. And I thought this was very common, comes up all the time, and we need better information on what we need to do about it. This isn't the full answer, but I think it gives us some good information about this condition that, again, I say we see all the time, and there's a little bit of uncertainty of how we should manage this.
Okay, and we're moving on to our third study of the morning. And we're switching gears here and talking about a bit more of hepatology.
Yeah, totally switching gears. So this was a randomized trial of Resmetirom in NASH, or now called MASH, with liver fibrosis. So this is a New England Journal. This is back in February 2024. And basically what they're taking here is they're taking patients who have biopsy-confirmed steatohepatitis, along with fibrosis in their liver. And then they're, of course, using this medication, Resmetirom, versus placebo. And they had two different doses of Resmetirom. They had an 80 milligram dose and a 100 milligram dose, and again, it's versus placebo. So your question might be, what is Resmetirom? I certainly didn't know. But it's actually a thyroid hormone beta receptor agonist. Sounded odd to me, but apparently that's quite active in the liver and has a role to play in terms of development of hepatitis, steatohepatitis, and fibrosis. So it's actually a thyroid hormone receptor agonist.
And I think this trial is really interesting because, as we all currently know, there's right now no medication that we can really give to treat NASH or MASH, and it's really more sort of weight loss, diet, exercise, that sort of thing. So it's an interesting study question for sure. And what was their study design?
So again, all these patients to be entered, they had to have proven hepatitis and fibrosis by biopsy. So the patients would have had a biopsy at screening, and then they would have a biopsy again at the end of the study, so at 1 year mark. And effectively, again, you got your medication or placebo. And in terms of the outcome, this was resolution of the steatohepatitis by greater than 2 points on the NAFLD score, or improvement of the fibrosis by greater than 1 stage on the fibrosis score. So those were your outcomes, really, either improvement in steatohepatitis or improvement in the fibrosis. And this is, of course, through biopsy.
And what types of patients did they end up including in the study?
So the patients are I think for the most part, what you might expect for a study of steatohepatitis. So the average age was about 56. This is, again, about 43% male, so almost 50-50. It's an average BMI of 35, so these are obese patients overall. And they have significant comorbidities. About 70% of these patients have diabetes, 70% have hypertension, and 70% have hyperlipidemia. So it's a fairly comorbid group of patients. And again, in this study, just like the previous one, over 90% are Caucasian. So it's not highly representative, but that was their study group.
Okay, what did they find?
So their results basically show that if you look at resolution of the steatohepatitis, and again, that was by more than 2 points in their scoring system, it was about a 20% improvement in the steatohepatitis. If you look at the fibrosis, it's about a 12% improvement in fibrosis. If you look at patients who had both their fibrosis and their steatohepatitis improve, again, about a 12% difference in that. So overall, they did show a significant improvement. And I will say that based upon this study and some previous studies, this has actually been approved in the US, not in Canada, but this is the first drug approved in the US now for treatment of steatohepatitis.
I'm surprised to learn that was fast.
Yeah.
And can you tell us a bit about the side effects that were reported to the drug?
So the main side effect was diarrhea. And the diarrhea, their rate was about 30% versus about 15% in the placebo group. The diarrhea generally resolved within a month, but that would be the most common side effect. Most of the other side effects were not significantly different, except there was one interesting difference, which was that the free T4 levels did decrease by about 15 to 20% in the intervention group. Now the TSH did change and the free T3 didn't change, but the free T4 did go down by almost 20%. And no outcomes, of course, this was not an outcome study, but that's an interesting side effect.
Right, and as we mentioned, perhaps that the drug is a thyroid hormone receptor, beta-selective agonist is the mechanism of action.
Correct.
Something to be aware of, I suppose. And you sort of alluded to this already. What was the main limitation of this study?
Well, there's obviously a number of limitations. Number one, for the group, right, this is very clearly a drug-sponsored study, so you got to be a little bit cautious. This study is biopsy only. There was no clinical outcomes in this study. It's only about biopsy. And it's a bit unclear what the long-term effects of this medication are, because again, it's only a 1-year exposure for a condition that I think has sort of ongoing effects. And in terms of the outcome, I will point out that this study is being extended out to 54 months with a view to seeing if they can get some clinical outcomes. This was only a 12-month study. They are going to extend this out to 54 months. I will also point out that the drug is not cheap, as you would expect. It costs about $50,000 a year in the US, which was interestingly set at exactly the level that they thought would achieve adequate cost for quality for benefit when they did their analysis in the US, and that's basically exactly how the drug company set their price once that analysis came out.
So not the cheapest drug, but also I guess not the most expensive. So, and why did you include the study?
So so I included this study because, again, this condition, we see this all the time. We probably under-recognize it, quite frankly, but I think we see it all the time. Present estimates in Canada would be that we actually have 9 million cases in Canada of MASH or NASH. So it's very prevalent. And we have about 2.5 million cases of actual steatohepatitis in Canada. Of all the fatty liver disease, we have about 2.5 million of actual steatohepatitis. This is incredibly prevalent, and it's of course increasing in prevalence. And it's become the #1 source of cirrhosis at this point, the #1 source of long-term liver disease in Canada, and growing exponentially, basically. So obviously a huge public health issue for us, and an issue that we don't really have a lot to offer at this point. And again, I think we're at the beginning of looking at interventions to sort of alter the natural course of this, and I think we need to figure out ways to alter the course of this disease, because again, it's just so prevalent.
Yeah, I agree. This is huge. Potentially having a pharmacotherapy for NASH and MASH. It's a really big step forward. But of course, with all the limitations that you mentioned, and I'm sure there's more future research to come on the drug itself. So I think we're ready for our fourth. Where are we at now? I think it's fourth. you're all used to COVID trials, but this is a COVID trial with a twist because it's actually not about COVID, it's about long COVID, which I think we all see in our outpatient practices quite a bit, as well as inpatient as well. So can you please tell us the title of this one?
So this title of this study is about the effectiveness of COVID vaccines to prevent long COVID. So this is a cohort study in Europe. So this is basically looking at cohorts of patients in the UK, in Spain, Catalonia, Spain to be particular, and Estonia. And again, this is a population-based database study of these patients, and this is really during the initial COVID vaccine era in 2021.
And what was their research question?
So the real research question is, does vaccination impart any protection against long COVID? That's really the main research question here. So let's go into a little bit of detail about what is the definition and how do you do this. So vaccination is pretty easy. These are databases. They've got pretty robust databases, so they'll know which patients got vaccinated and which patients do not. In terms of how do you define long COVID, well, that's obviously more difficult, right? There are some guidelines out there for definition, but really it's very hard to define it prospectively. And certainly at that time, they probably wouldn't have had it. But what they really did is, there is a WHO definition with numerous symptoms. There was about 25 symptoms that would qualify as long COVID symptoms, just to put that into some perspective, right? There were about 25 symptoms that they used. And effectively, if you developed any of those symptoms in the coding database after you developed COVID, so it had to be 3 months after you developed a known COVID case, if you had this new symptom show up in the coding database that had not shown up previously in your medical history in the coding database, then they would be defined as having long COVID. So you had one of these 25 symptoms that had showed up as a new thing in your coding database for the patient a minimum of 3 months after the development of COVID infection.
I think that makes sense. I think they tried the best they could to sort of define it, despite the sort of vague definition of long COVID. I think the methods make sense in that context.
So I think let me explain a little bit more about what you're going to see in the results. So there's 4 cohorts in this study. So number one, there's 4 databases. 2 of them are UK, 1 Spain, and 1 is Estonia. In total, this study had 20 million people in it when you looked at the database. So it's a huge study, 20 million. The vast majority are in the UK. Roughly 13 or 14 million of those 20 million were in the UK. So it's mostly a UK study. But the cohorts, there's 4 cohorts. And again, I would take you back in time to 2021. So this really ran from January of 2021 to July of 21. And the first cohort, cohorts 1 to 4. So cohort 1 basically related to when people were allowed to get vaccinations. And again, you got to go back in time and remember how that happened, how it rolled out. So cohort 1 was basically patients above the age of 75, right? That's the first cohort that got vaccination. Cohort 2 was above the age of 65, and then people with medical illnesses that put them at risk. Cohort 3 was over the age of 50, and then cohort 4 was basically all comers that are adults, right, over the age of 18. So that's how the cohorts were done. So it's, you're going from higher risk down to average risk, I would say. But again, that relates to how vaccines rolled out back then. There was 2 main vaccines used here. The first one is really the Pfizer vaccine, the mRNA, and the second one is the AstraZeneca vaccine that's no longer available.
Thank you for reminding us of the cohorts, because I, for one, got bogged down reading the study. I couldn't understand why they had designed or studied the cohorts in the way that they did, but as a nice reminder for how the vaccines were initially rolled out, that's very helpful to contextualize. So the patients that they did include, what did they look like? So basically, at the end of the day, they did show that there was a decrease in long COVID if you were vaccinated. The effect is about 30 to 50%, but I would actually say the 2 biggest cohorts are the CPRD cohorts, which is actually the UK cohorts, and like I said, that was roughly 60 to 70% of the total population. About 70% of the total population was in the UK. So in those big cohorts, it was actually closer to 50% effectiveness at preventing long COVID. So overall, showed, I would say, a fairly significant protective effect. Lots of different pathophysiologic mechanisms as to how that may be, but nonetheless, it definitely shows some protection there. And I think the nice thing is I was listening to a commentary
So you're going to ask me next, I'm sure, is what are the issues with this study? Well, of course, this is database, right? It's retrospective, it's a database study. It relies upon coding. Anybody who does database studies realizes that your biggest limitation is how accurate is the coding. So coding accuracy always becomes an issue. I will say when they deal with 20 million patients at a population level, some of those issues become, I think, sort of washed out, and it has a little bit more accuracy in that situation. So why did I pick this study? So I think for me, number one is I think long COVID is incredibly common. We have so many cases. It's roughly about 10 to 20% of patients, at least during the initial phases of COVID, were thought to develop long COVID. Right? So this is a huge population that has symptoms that would qualify as long COVID. Is it real? I'm convinced it's real. I think it's a real entity. I think it does exist. There is some sort of long-standing effect on a number of patients. I would suspect that everyone in this room probably knows somebody with long COVID or something that's defined as long COVID. I personally have colleagues who I know have what we may call long COVID. I know a number of people who have it. I think almost everyone in this room, again, I would say, knows somebody with it. So I think it's a huge issue. We don't really have a lot. This is not meant to be about how do you treat it, but it's meant to be about is it out there, and is there any way we can actually prevent it? Because that's probably the most important thing. And in society, I guess I would see that we have an increasing hesitancy to use vaccines now for COVID. It's become politicized to some degree, but there's definitely an increasing hesitancy. People say, I've already got vaccines, I'm good, or I've had an infection. But this study shows, and of importance, it's even in the young patients who are probably the most vaccine hesitant sometimes, which is cohort 4, it still showed a significant benefit. I think this gives us some information that we may have a tool and a way to sort of try to sort of give some education to patients about, as COVID maybe isn't as virulent as it used to be in terms of the effects, but long COVID is actually at this point still thought to be a significant risk, even with the less virulent actual clinical manifestations of COVID. And this is at least maybe a way for us to try to impact this and give some public education about ways to prevent this complication that once it's there, we have no real treatment for at this point.
I totally agree. I think it's very timely to talk about this study as well. COVID vaccines or boosters are just rolling out right now. I know one hospital is going to be rolling them out for our patients next week, and it gives us something else in our toolkit for those conversations about benefits, risks with patients. Okay, we are ready now for our 5th and final trial of this morning. Can you start us off with the title and the research question?
So the final trial is about the efficacy and safety of steroid therapy for community-acquired pneumonia. It's a meta-analysis and meta-regression of randomized controlled trials.
This is an age-old question that we are always sort of, especially in the past few years, thinking about as we treat our patients with pneumonia. And what was the research question?
So the question is fairly straightforward. So basically, the question is, what is the effect of steroid therapy in community-acquired pneumonia on all-cause mortality? So the main outcome they looked at is actually all-cause mortality, which I like as an outcome because it's kind of hard to argue with.
Fair. And can you tell us a bit about the study design?
So effectively, this is was a systematic review, a meta-analysis and a meta-regression, looking at, of course, all of the published literature in this area. There have been a number of these before. This one included some more recent studies, and that's why it's, I think, of some relevance here. I think it looked at about 30,000 articles, like all meta-analyses do, and they sort of distilled it down, and by the end of it, they ended up with 15 articles that they used in this meta-analysis. And their main outcomes were 30-day all-cause mortality, and then the other outcomes were, of course, as you would expect, ICU admission, hospital stay, development of ARDS, time to clinical stability, a whole bunch of sub-outcomes, but the main outcome was 30-day all-cause mortality.
And when they included a corticosteroid treatment, within the studies, what was kind of the variation of the different corticosteroids?
So, of course, there's a number of different corticosteroid regimens out there. So they had variations with hydrocortisone, methylprednisolone, dexamethasone, prednisone. So various corticosteroids are used, and part of the issue is steroid regimens do vary. What they did do is they did an analysis looking at greater in total exposure to steroids greater than 400 milligrams of prednisone in total versus less than 400 milligrams of prednisone in total. And so that was one of their analyses. Different regimens are out there. I would say on average, most regimens use something in the range of 40, 50, 60 milligrams of prednisone a day in the initial phase of whatever steroid they use, and then use that for 4 days, 5 days, sometimes up to 8, and then taper down. But of course, there's no set regimen at this point.
Exactly, and I think it was important for them to try to include as many studies as they could with that caveat that the formulations were different. In the end, what types of patients did they include?
So being a meta-analysis, it's hard to have a good picture of all the patients, but on the average, these patients were in their 60s, pretty common for the ward, mostly male, 60% male. And then not a whole lot of characteristics beyond that. Again, 15 studies. I would say the majority of these studies were actually European. So I think out of those 15, 9 or 10 of those were European studies. But of relevance to us, it was a mixture of ICU and ward. So this was not a pure ICU study. In fact, over half of these studies had patients on the ward. And then the rest would be in a step-down unit or an ICU. But this was a mixture of patients in various settings.
Which makes, of course, as you're saying, the results very interesting to us. So please tell us, should we be using steroids for patients with pneumonia?
So their headline result, all-cause mortality, showed almost a 3% improvement in all-cause mortality with the use of steroids. In most of their subgroups, there was an improvement in ARDS as well, where it was about a 2.5% decrease in the development of ARDS. Of interest, the steroid group had almost no ARDS develop. The only other outcome that was significant that I didn't list up there was time to clinical stability, which was down to about 4 days from 5 days. So there was a 1 day decrease in time to clinical stability. All their other outcomes were really not significant, but I think their main outcome, and the one that I would worry about the most, all-cause mortality, did have a 3% difference there. In terms of adverse events, again, they looked at a number, exactly what you might expect. Hyperglycemia, 20% versus 10%. Of course, you have higher sugars when you use high-dose steroids. But all the other major adverse events did not turn out to be significantly different in these groups. The final thing I would show you on this is they did look at a number of subgroups. Honestly, there was not a whole lot of difference, except that the top there is severe pneumonias versus less severe pneumonias. So almost all the effect turned out to be in severe pneumonias. And you have a relative risk of 0.56 there for severe pneumonias, and for non-severe pneumonias, there's really turned out to be no difference. So what does severe pneumonia mean? Of course, the definitions differ. It could be the British Thoracic Society, the American Thoracic Society scores. It could be the Pneumonia Severity Index. It could be something like the CURB 65. But any of those scoring systems that would define you as being a severe pneumonia would be part of that definition. And that's where this effect seemed to be mostly limited, is those patients who were considered to have a severe pneumonia on admission.
And I found that to be really important too. I know prior to this meta-analysis, there were several studies being pro-steroids, several being against steroids, and perhaps this is sort of what formed some of that clinical questioning there, is that perhaps it's mostly because that for severe pneumonia, this is really where you see the benefit of steroids.
So why did I pick this study? So for me, again, ridiculously common, right? This is one of the most common things we're going to see as interns, right? We're admitting pneumonias all the time. And then there's this whole question of what can we do to improve their outcomes. And this whole steroid question keeps coming up, comes back and forth, just like in sepsis, and it's coming back again. So now, there's been some data about steroids in sepsis, steroids in the ICU, and even in that group, it seems like pneumonia seems to have a preferential benefit, even in the ICU setting when you use steroids. And so what I find interesting is that there does still seem to be a sort of a reluctance to think about steroids in pneumonia. I always find it interesting because there's no reluctance to use them in COPD exacerbations, where they're given like candy, but there's actually no mortality benefit in COPD, but we use it all the time. But yet there's definitely a reluctance in pneumonia. This information has been sort of bubbling up over the last little while, but previous meta-analyses haven't been definitive. I'm not sure if this one is definitive, but this one definitely, I think, shows what I would consider a fairly significant clinical benefit. I think a 3% absolute mortality benefit, it's hard to argue with.
Yeah. So that we don't seem biased, can you briefly tell us about the limitations, and then I'm going to ask you, this is practice changing for you?
Well, the limitations, of course, it's a study looking at analyses. What's your definition? There's some heterogeneity, although their actual heterogeneity turned out to be not too bad when they did their analyses on it. But there is some heterogeneity in the studies and in terms of the settings of it. But overall, I would say it's a pretty reasonably well done study. Would this change my practice? The answer for me is yes. I think this would. What this probably is going to make me do is actually go through the exercise of thinking about if it's a severe pneumonia, maybe actually trying to do a curve 65 score more routinely, which I don't all the time right now, but maybe I should do that more often.
Don't tell us it's not
and I do think that for me, this does give me some sort of backing to say that I think we should be using steroids in these sicker patients, and I think that the effect is probably real. And it makes sense when you look at it at other settings, right? COVID pneumonias, this was one of the first things, right? Steroids were one of the most important things in COVID pneumonia. And it makes sense from an inflammatory response perspective, just like in sepsis. So I think there's plausibility biologically, and now we have some evidence. I think I would definitely be using it now, again, in severe pneumonias only.
Right, I think it's pretty cool and very practice changing. You know, it does raise more questions, like if we are giving steroids, you know, what dose, what type, how long. But those are all questions that I am sure there will be more research and data for in the future. So it's very exciting. We're doing quite well on time, actually. So there it is, everyone, the rapid fire top 5 papers of the year, according to us. So we actually have some time, so we'll open it up to the audience for any questions. So while it's kind of simmering in your head, I'm just going to ask Raj a final question. And so sorry, if you do have questions, there's 2 microphones there and there that you can go up to. So for my final question to you, can you provide us an overall summary of your thoughts from the past 5 papers?
Absolutely. So, top 5 papers, there's no agreement. There's no way to agree. Right? You go through and you pick 5 papers that you think are interesting. Why did I, at the end up on this 5 papers? I think for me, if you look at this, we've hit upon multiple different areas, right? We've hit upon some infectious disease, we've hit upon some cardiology, we've hit upon some GI, we've hit upon different areas of care, we've hit upon preventive health care, we've hit upon also primary care level, and we've hit upon acute care. So we've sort of spanned multiple clinical areas, we've spanned multiple areas for care to be delivered, and to me, that is GIM. And I think it shows you the breadth of what GIM is about, and how we have a role in multiple different, not just clinical settings, but also, what kind of care settings do we operate in. So I thought this was fairly representative of what GIM is about.
100%. I think it's a great way to kick off the second day of the conference that really celebrates GIM and everything it has to offer. So thank you.
Very well, time for questions. First question over here.
Hi, Stephen Wall from Toronto. Thanks so much to both of you for an outstanding presentation. And I definitely will be doing way more pneumonia severity scores in the future. I had a question about the COVID-19 study. I was wondering if you think it's hazardous to generalize from a study of vaccinated versus unvaccinated people to present day when people are considering getting their 5th booster shot?
Excellent question, and I think we don't know the answer to that, right? And obviously that would require another study. What is the enduring effect of a vaccine from a year ago or 2 years ago? And that's a question I don't think we know the answer to. So you raise a valid point. For me, this was important to show that we had something that could show some benefit for this condition. But I agree with you. I don't know what the answer is. Is the 6th vaccine as important as the 2nd vaccine was? I don't know that we have that answer.
Thank you.
Good morning. Thank you. My name is Linda Sineda. I'm from Zahra. I'm an endocrinologist. I'm curious to know what the efficacy for lifestyle modification is when we're talking about NASH. So we looked at Resmetirom versus placebo. but not versus another active, I think, very important form of treatment. Any information on that?
So I think you bring up the huge point about this whole pharmacologic intervention in steatohepatitis, which is what is the role of non-pharmacologic intervention. So I think it's 100% valid. I actually agree with you that that's probably the ideal, and that's probably the only therapy up to this point that has been shown to be effective. The issue is it's also very difficult, and it doesn't work. Like a lot of people have difficulty sticking with it. So this is a pharmacologic intervention, not compared with anything else that I'm aware of at this point, except for placebo. But I think it gives you another thing in the armamentarium. Maybe it shouldn't be the first thing. I would 100% agree. This should never be your first thing. I think the number one thing should be lifestyle, because the other issue here is this lifelong therapy? Like, is it a year? Is it lifelong? Like, obviously it's hugely costly. Or is it a bridge to other therapies? Is it a bridge to sort of a lifestyle modification? Just like Ozempic is, right, for weight loss. It's the same issues, right? What's the goal, end goal here? Is it lifelong therapy, or do we change things otherwise? And I think those are very valid points. I think this is just another tool, but it should not be your first. It should not be your first thing to go to.
I agree, because if you look at health economics, if we're going to be spending $50,000 a year on this drug, but we can implement lifestyle modification on a broad base for significantly less, we need to understand what our relative efficacies are going. And I think, if you're going to use the drug, would you not be also implementing lifestyle modification at the same time? So comparison to placebo is just what I don't think is the right thing for this study.
Yeah,
But
thank you for pointing that out.
It's pharmaceuticals.
I'm trying to think. I don't think I remember reading anything about like a standard of care or lifestyle interventions within that study. So yeah.
Let's just all the way for a few more questions. What is the availability of the testing for the biomarkers for Alzheimer's in Canada? Can you comment on that? Is it here? Is it ready for prime time? Is it a year away?
Excellent question. So that's actually one of the major issues with that test. So that's actually a test that is very difficult to do and is not widely available at this point. So that is one of the issues. I think there was only one lab in the US that was doing this test, and of course some labs in Europe. But this was a mass spectrometry, I believe, was how this test was done, which is not something that's going to be able to be rolled out widely. So this particular test may not be what in the end of the day becomes more commonplace, unless they can find ways to do it in more efficient ways. But I would say that that's an area that is honestly being looked at very actively. They're looking at, there's about 50 tests in the pipeline right now. But yeah, these tests, the way they did it right now, that's one of their big limitations. They can't roll it out widely right now.
Yeah, you could probably argue that a lumbar puncture would be easier at this point than the mass spectrometry or the PET scan. But of course, in the future, the goal is to make it easier.
Thank you. Question?
Zahra from Hamilton. So rather, the study about Alzheimer's study, how good are the gold standards for Alzheimer's right now? Because LP and PET scan, are there scores in there?
So this was actually learning for me, because I didn't realize where we were with it. But from my reading, this is as close as we come to a gold standard right now, and this is actually considered quite good. What is the gold standard for Alzheimer's is part of the problem, right? Pathology at the end of life, maybe, but obviously that's not a good gold standard. But this, I didn't realize this until I looked into this, but the CSF studies are actually considered basically at over 90% predictive. So they're considered actually the closest we have to the gold standard right now.
Rajender from Hamilton. Zahra, fantastic job. I was going to ask, there's a lot of new sort of faculty trainees in the room. Raj, could you talk to us a bit about your process for staying up to date? We saw from Sandy Coley yesterday that there's an exponential rise in the publications that are coming out. What is your process? Do you have some advice on how we can stay up to date with internal medicine?
Well, that's a great question.
Yeah, excellent question. Very, very difficult. And actually, when you start going through the literature, it's like overwhelming, right? How much stuff there is out there. But for me, so number one, I'm lucky. I work in an academic center. Residents are actually great at keeping you up to date. But that's obviously not going to be applicable for everyone. But for me, what I find is these summaries that are available, whether it be evidence updates, whether it be ACP Journal Club, New England Journal of Medicine Evidence. Right? There's a number of these publications that summarize major evidence for you. There's no way you're going to be able to keep up with every journal's publishings and read them and try to analyze it. It's just impossible. So I think you end up having to use some of these other tools that are out there, and there's a number of them out there. And I sort of listed some of them. I think that's what you have to do. And then word of mouth, right? Just be open to listening to what other people have to tell you and be curious. I think the biggest thing is when you hear something, be curious enough to look it up, right? Because that's, for me, actually how you stay up to date with stuff, right? So a combination of all of that.
You know what, I'll do a bit of a shameless plug to Medicine Pods as well. That's really what we're trying to do on the website. We have an evidence-based medicine sort of section where you can subscribe to sort of like ChatGPT summaries of trials. And then the Rounds Table and the Internet Work podcast are really trying to produce podcasts weekly to keep everyone up to date.
And I should actually say that is actually, thanks for reminding me. I've actually started doing that in the last couple of years. It's addictive actually. Like, I love it, this podcasting thing. I listen to podcasts all the time as I'm driving in, and it's actually very useful. And I would actually encourage people to try it out. It's time that you aren't doing much anyway, and it's super effective actually.
I'm just kind of learning through osmosis. So if there's no other questions, maybe I'll close up. So thank you to CSIM for having Medicine Pods this year, and thank you to Dr. Hanmiah. I'm really in awe of how you kept all these studies in your head and just had a very candid conversation with all of us. So to our live and Internet Work audience, thanks for tuning in, and we hope to see you again soon.